Let's welcome Mr. Osborne and Mr. Howard Cimring.
Thank you very much, Stanley. Hello, everybody. This one. It's afternoon, it's after tea. It's late, you're drained, you're full. So we're trying something different. And actuaries aren't the most exciting people in the world. Actuaries...
Speak for yourself.
Speak for myself? All right. We aren't the most exciting people in the world, and neither is our topic most exciting in the world. But so last night, after the cocktail party, I went to look for a milkshake. I heard they had really good milkshakes at the ice cream place. I figure, we've prepaid, they're open, there's no money needed, I figure milkshake will be there. So I went there and I asked for a milkshake. He said, after 9 o'clock, no milkshakes. So what do you mean no milkshakes after 9 o'clock? Well, that's our policy. Howard follows me down, having told me they have great milkshakes, and about 10 minutes after me, he doesn't get one either. So we sit down on stools like we are now, under the stars last night, trying to solve problems such as fully paid systems not providing milkshakes. And Howard says...
Now, I have immense respect for their policy. They are following a rules-based system. No milkshakes after 9 o'clock. Now, can you imagine if we applied the same to our systems? Health insurance is a rules-based system. How many times do we go above and beyond our rules? How many times do we do things that perhaps we shouldn't do? Maybe they're undocumented. Maybe it's of an ex gratia nature. But I have immense respect for those that follow a rules-based system. Do we need more of that? So I wasn't not unhappy. I didn't make a fuss.
I wasn't happy.
Derek might have been unhappy, but follow the rules.
Okay, so back to our topic at hand. It's about risk and risk management. And as you know, actuaries, sometimes you call upon us to help and make projections, but also assess the risk that you're exposed to and how to mitigate that risk along the way. So Howard, what is more important than risk management? Is there anything more important than risk management?
There actually is, Derek. And of course, a lot of what we do is risk-based in nature. So risk management is very close to our heart. But there is actually one more thing that I think is more important than risk management, and that is good governance. We're constantly striving for good governance. And for us, good governance is aspirational. You might have good governance, but you can always have better governance. And what does that mean? We've heard throughout this conference reference to governance. And to many people, governance means different things. But we're talking about the fundamentals of how do you organize yourself. If you don't have defined objectives, you'll never know if you're successful. So how do you organize yourselves from a decision-making standpoint? How do you make sure that you have the right people in the right roles? Are these roles defined? Have you set the experience, knowledge, and educational criteria in order to participate in the process? If you can't fill these roles, where do you look for help? That's okay. You can always rely on external help. That's part of good governance. For me, Derek, it all starts with good governance. If you don't have the fundamentals of good governance in place, you can't set or manage risk properly.
And you really believe that better governance produces better governance?
I do. Like I said, good governance, better governance is constantly aspirational. You should never say we've done enough, that we've attained a level that is satisfactory. Keep going. You can always do better. Now, can it produce better outcomes? Let's just turn the conversation towards risk management. In the field that all of you work, in the provision of healthcare services, health coverage of contingent events, this is an incredibly risky business. There are a plethora of risks that you face every day. There's the obvious one of solvency. Do we have enough money in the bank to pay the claims for the next couple of weeks? Now, you'd be surprised at how often and how challenging the management of just solvency might be. But what about some of the other risks? And we've heard some of them before: aging, aging of the population. That's something that may not be imminent, but it's coming down the tracks. So from a risk management standpoint, we like to classify risks along the following dimensions. We want to know what is the severity of the risk and what is the likelihood of the risk. But I'll add one more dimension, and that is the dimension of time. So how imminent is the risk? Is it immediate in nature? Is it a short-term risk? Is it a long-term risk? And each of these risks have to be categorized and identified, and the tolerance for the risk needs to be assessed. But also, how can you influence your exposure to the risk? And think of all the risks. Some of the risks, you are not able to influence them. You just need to have awareness that you've accepted the risk, and then have a strategy in place in order to deal with the risk and to mitigate the risk. So whether it's aging, whether it's climate risks, I mean, think of a hurricane, think of erosion of the shoreline or rising of sea level, think of virus-related risks. I mean, COVID is the obvious, but this region has had chikungunya, SARS. What's the next one? Think about the operational risks, financing risks, people risk, succession risk, IT risk. There are a whole host of risks that you manage, and of course establishing some structure around those risks is going to be immensely important and can produce better outcomes. Now, what about, there was also talk through the conference of catastrophic risk, okay? Can you hedge yourself against catastrophic risk? Can you diversify that risk away? And that is incredibly challenging. I've worked with some organizations that have to deal with catastrophic risk. And of course, we have modeling that we can perform, and we can do stress testing and illustrate a number of scenarios to quantify the effect of the catastrophic risk. But there are probably very, very few organizations that have sufficient capital to support and sustain and to absorb catastrophic risk. Now, where might you turn to in the event of a catastrophic event? Is it going to be government, or are you going to push that risk out into the reinsurance markets? But it's I'd say very unlikely that you would be able to absorb the catastrophic risk within your own capital framework. So it's all good and well to recognize that you are exposed to these risks, but how do you organize yourselves to manage those and to fund them and to finance them? That's going to be key. And are there, where do you find the backstop? And does the counterparty to that risk, are they aware? Okay? One of the, I think the biggest difficulties that I've encountered in working with a number of national health insurance plans is that the counterparty, so to speak, of the risk is not even aware that they are the counterparty. There are implied agreements, but nothing in writing, and this comes back to good governance. There needs to be clarity amongst the various parties of what is expected of them. So if you're expecting government to bridge your financing if you run into a solvency deficiency or a liquidity crisis, is government aware that they are the counterparty to your risk, or are you intended to manage your operation on your own? And there's, I think, maybe I'm digressing a bit here, but there is some weakness in budgeting, because budgets are set at levels that are unrealistically low, and when expenditure blows past those initial budgets, is anyone surprised? It's going to happen. We know it. We all know it's going to happen. So why is there not good governance around this? Why are these not well documented? I mean, this is it's a gaping risk. If the counterparty is not aware that they are going to have exposure to that risk, I think it hamstrings the whole system. It really is difficult to organize oneself from an operational and risk management standpoint if you don't have clarity amongst all the parties from a risk management standpoint.
Yeah, and just to add to that, Howard, I think one thing we have to realize too is that when government steps in to help foot the bill, it's essentially the same people who are paying contributions to NHI and other schemes who are paying the bill, because taxes come from essentially the same group of the people who pay contributions.
Right.
And so we have many governments who are afraid to implement a contribution rate for the NHI program or to raise the rate as necessary, but the money still comes from the people.
Right, that's so true. So there's generally a reluctance amongst governments to raise the contribution rates to fund these programs. And ultimately, the backstop is going to fall onto government. And who's funding government? The people are funding government. And so it's just a tax, it's a contribution hike, but just in another form.
Taxation, right. So moving to actuarial stuff. So we talked about COVID the last few days. We've heard a lot of people having to change behavior, in terms of what they do and how they do what they do. As actuaries, are we doing anything differently going forward that we didn't do before, given the experience of COVID and the financial impact, both on the income side and on the expenditure side?
Sadly to say, COVID is a technician's dream. There's so much data out there, so much interesting data that we've been able to analyze. We've heard about some of it this morning, where during the lockdowns, some of the medical care was unable to be delivered. Some of it came back in the months that followed. Some of it never came back. So we're having to look at the data very carefully, look at the expenditure through time, how it changes, what is the new baseline, how do we kind of compartmentalize that data so that it doesn't influence the impact of our longer term trends. So it's been really interesting to see how all of the different systems have been affected differently, and also the timeline. It's interesting to track the measures that were affected by government, whether it was a lockdown or otherwise, and how that starts to change the data, and what happens as life returns to normal. But I think one of the questions that are still kind of unanswered for us is, what is the effect of the longer term tail impact of this? Because I'm not sure that we fully are through the impact of COVID. We've heard of the surgical backlogs. We know that some people have not been able to attain their treatment. What's going to be the longer term impact on morbidity? So, and I think the question of long COVID is still out there. There's a great percentage of the population that now has contracted COVID, and we don't yet know what the impact of long COVID might be, and how it's going to play out under the expenditure of these health insurance plans. So that's been really interesting, Derek.
Yeah. And you mentioned lockdown a couple of times. I know that for 2 years, you were in Toronto, in your basement, locked, as we say, lock up, right, in your basement. And I'm sure you were thinking and modeling and doing a lot of stuff. Well, what's new? What kind of formulas have you come up with that in the healthcare space that we haven't heard of before, that folks should be exposed to?
Well, there's always the age-old actuarial formula, and I know everyone in the room thinks that actuaries can solve all equations, but there are actually equations that we cannot solve. And I liked actually some of Lex's. He showed like a nice equation of the payer, provider, and politician. Well, we have a different equation. Kind kind of conceptualize just three variables, X, Y, and Z. And in the context of health insurance arrangements, these represent funding. The second dimension is benefits, what do you cover? And the third simply would be, what do you reimburse? Whether that's the rate that you pay the provider, or whether there's a copay or a deductible put on the plan, that's the reimbursement equation. Now, we can only solve that equation if we know two of the three components. So if you want to know how much, if you tell me these are the benefits we want to cover, this is how much we're going to reimburse, I can tell you how much you need in funding. Conversely, if you don't know what your reimbursement might be, but you know what you want to cover and you know what your funding is, I can tell you what the reimbursement must be to satisfy that equation. But unfortunately, sometimes our clients come to us and they expect the actuary to solve the X, Y, and Z without any of those pre-populated parameters. They don't know what their funding is, they haven't set the benefits, and they don't know anything about the reimbursement yet. And Mr. Actuary, can you model this for us? Well, I'd be wasting time and money if we were to try and solve that equation, because the possibilities are infinite. So there's a lot, my advice to any of you that are on this path towards national health insurance or universal health care, there's certain groundwork that must be done beforehand. There's kind of a sequence of events that you must follow before you undertake the actuarial analysis. And when you get to that right point in time, we can solve the equation.
I hear you, but the client has some funding from a donor agency. They've been told the actuarial study is necessary for the government to make a decision. And they approach you and they say, well, Mr. Howard, you're the smart guy in the room. We've heard about you. You've become highly recommended. We have 3 months to have this proposal ready, right? They don't know everything that we know, or that you know. How do you help them know what they don't know? And how do you tell a client who has this short-term funding to get something done that you ask them the wrong question? You should be really doing A, B, and C first before you come to us as D.
It's all about being direct and honest. We sometimes find ourselves in a difficult position. It's difficult to have to convey that message back to the client. We can try our best to help you, and we want obviously to have to optimize the outcomes. We want that information to be as useful and as relevant as possible. We don't want our projection to sit on the shelf and give you a pretty 20-page report and then you file it away and you never sees the day of light again. Because by the time it's pulled out of the folder, 5 years have passed and the world has changed. So, we have to have those difficult conversations.
Yeah, and truth be told, we've had a couple of those. That's the true story. And so I know we don't have much time, Stanley. 2 minutes?
2 minutes.
All right, so final question, Howard. What's new and sexy in the world of actuarial science and data analytics?
Yeah,
what's sexy?
Sexy for me, believe it or not, is data visualization. There's an incredible advancement in the world of data visualization. We talk of liquid data now, data that is easily usable and is ready for analysis. AI tools can be applied to the data for predictive analytical purposes. But it's become so easy that I'm willing to say that any one of you in the room can now produce live dashboards. You can splice and dice your data any which way you like. And this can hang on top of all of the IT tools that you have. It's really cool, so exciting. And the other thing that that I find exciting is the whole field of behavioral analysis. Now, what does that mean? There's been a lot of studies, like whether it's behavioral finance, behavioral economics, behavioral behavioral actions in healthcare. So let's talk about some of those examples and give you some food for thought, because I think this lends itself directly to some of the challenges that you all have in this room. Let's just start with the example of the behavioral economics around deferred gratification and instant reward. Now what does that mean? I'll use the example, and some of you may have seen it before, where they take kids and they put them in a room and they put one candy in front of them, and they tell them, if you wait 20 minutes and don't touch the candy, after that, those 20 minutes we'll give you 3 candies. But if you eat the candy, the one candy in front of you, then that's all you get, all right? And you see these kids sitting there and they're in agony, absolute agony, with the temptation of the candy in front of them, and invariably most of them eat the candy. That's the instant reward. Deferred gratification is really tough. We know that when we have to save for retirement. Putting money aside today is, it will secure your retirement, but it's much more fun to take that money and spend it now. So in the field of behavioral finance, for pension plans, in the context of pension plans, employers are encouraging their employees to save money by matching. So for every dollar you put in, we'll put in $1, and that encourages better behavior. But how does this apply in the field of healthcare? You can almost think of this concept of deferred gratification and instant reward by trading off poor diet for exercise, a healthy lifestyle, as opposed to inactivity. Now, it's much easier for all of us to kind of blow caution to the wind, forget about diet, forget about exercise, just, follow unhealthy patterns in lifestyle. Instant reward, right? I don't want to have to. It's hard for us to see the future that by following a healthy lifestyle, we will have a reward later on down the line. It's hard for us to see that. As human beings, we're just not wired that way, all right? And rather, let's just indulge now, because I know that the medical interventions are there to catch me as the safety net. I know that there's like a hypertension pill, a drug pill, a surgery that will catch me if I happen to kind of require that intervention. And that's the transformation that I think you all have to, if there's ways through behavioral intervention that you've probably heard the word of nudge theory before. If you can nudge your population away from taking those, indulging in the instant gratification, but investing in the deferred gratification, then we're getting somewhere.
And we don't have time now, but we have to nudge our politicians to charge that phone before the battery dies, so it could last longer in terms of paying healthcare and paying pensions, right? So right. That's for next year.
So, yeah, definitely. Year. It's a topic that's so interesting. You can talk for hours on it.
Right. Thank you, Howard. Very good.
Sorry,
Thank you.
We're out of time.
Thank you very much, everybody.
All right. Good.